In this video, we are going to be discussing the neurological assessment. So when you are assessing patients that have a potential neurological disorder, it is important that the nurse knows the proper steps, as well as those normal findings in assessing the nervous system. So as a reminder, there is an outline that you may follow that will be included in the tab for the handouts. So you can follow along with that here. Okay, so assessment of the neurological system is going to begin with the history. So when you are obtaining a history, it is important to obtain a complete history from your patient because it is very important in determining neurological problems. Remember, anytime you are assessing history of your patient's illnesses, you want to go directly to that patient first. And if that patient is unavailable to speak, then you could use your patient's family member, but always go to that patient first. So you will be able to get this history by interviewing your patient, asking them the following questions that we're going to talk about. And of course, maybe, again, if you can't get it from the patient or all of it from the patient, then you can get the history from the family members if they are available. And hopefully they would be if your patient was to be nonverbal or for whatever reason you could not get information from them. So some questions that you do want to ask your patient about. Of course, you always want to start with that chief complaint. What is the reason that the patient is at the facility? What are the symptoms they're having? What brought them in? You also want to ask them about their past history. So this would be asking them questions about head or spinal cord trauma, if they've ever had a CVA or cerebral vascular accident or stroke, if they've had hypertension, meningitis, any circulatory problems, if they've ever had STDs, ever had hypoxic conditions, or also any cardiac risk factors. You would also want to ask the patient about those. So hopefully you've had cardiac by now, and you'll know that sometimes some of those risk factors or for some cardiac problems can put them at risk for neurological problems. Also, you want to talk about a family history. Ask your patient about any family history of any headaches, if they've ever had seizures in their family's history, Alzheimer's, because those, for example, are thought to be passed down by family members. So specifically, you would want to ask about those. You also want to ask the patient about their medication history, especially if they're on any medications such as any analgesics or sedatives, hypnotics, antipsychotics, and such drugs as those. And then you want to ask them about signs and symptoms of any neurological problems that they've had. So if the patient complains of one of these symptoms that we're going to talk about, then you would probably consider this to be a neuro problem, and you would want to focus on that. So some of the symptoms that could be related to neurological problems that you do want to ask your patient about are headaches. Headaches is a pretty main condition or symptom you want to ask about. So if a patient does complain of a headache, you do want to question them further, because there are many different types of headaches, and we will be discussing these when we discuss headaches. There's headaches that may begin in middle age. There's headaches that change in character. Headaches are sometimes associated with fever, increased intracranial pressure. They could have visual changes, migraines, and etc. And again, we'll be discussing those types later. But again, just be sure to ask them further questions about the different types of headaches and the symptoms that go along with the headache. So you do want to assess for the onset of the headache, especially asking if that headache's worse in the morning. You want to ask about precipitating factors or relieving factors. So if there's anything that brings the headache on, or if there's anything that helps the headache. The characteristics of the headache, so like, does it wake them up in the night? Is it dull or sharp pain? Is it unilateral, or is it all over? You also want to ask them about the severity of the headache, and then again, any other associated symptoms. So nausea, a lot of times, is an associated symptom with a headache. They could also have like photophobia, where they have light sensitivity, and there's others, but again, we'll go into more detail about those when we go over headaches. Also, you want to ask them about weakness or paralysis of any extremities. So if they've ever had weakness in their extremities, you want to make note of that. Any visual changes. So if they have any speech changes, also you would want to make note of that. If they've had seizures, so if they've ever had seizures, if they've had new seizures, or if they have seizures, they have a history of seizures and then those are worsening, you would want to make note of that. Also, if they've ever had any numbness or tingling in any of their extremities, or if they've ever had pain in those extremities, if they have increased irritability, mood swings, hallucinations, or personality changes, you would also want to make note of those. If they get very tired or fatigued, again, make note of that. If they've ever had tremors, memory loss, or then if they've ever had coordination or balance problems, clumsiness, you might have to word it as clumsiness, because again, remember, sometimes we have to word these things in layman's terms to the patients to make sure that they understand that what it is that they're asking. And then also you may ask them about any dizziness, if they've ever had a head injury, and then if they've ever had loss of consciousness. So you might would want to add that to some of your signs and symptoms that you may ask them about as well. Okay, the next part of the neuro assessment is going to be the mental status. Now, you all should be familiar with the mental status assessment that you went over in mental health. So some of this is similar, some of it's different, but you have a good understanding and good background knowledge for that, so that should help you understand the mental status. So it does include 6 different areas. It includes the level of consciousness, their orientation, their affect, their mood, their speech, and then cognition. So we'll talk about each of those. We'll break those down. So when you are talking about level of consciousness, or LOC, this is going to basically range from alertness to coma. So we're kind of talking about the patient's neurological status. So your LOC, it is the earliest and most sensitive sign of the patient's neurological status. It can indicate increased intracranial pressure. So if they have decreased level of consciousness, or if it's becomes more severe, over time, then that could indicate a problem with an increased intracranial pressure. So it is a very early sign and a very sensitive sign of the patient's neuro status. You do want to be sure to document the observations in terms of actual behavior and signs. So, for example, you don't want to chart that the patient's disoriented. You want to chart that there are actual comments that the patient maybe has made. So, for example, chart their behavior as they respond to verbal stimuli, or you could just document disoriented to time and place on awakening. So you need to be specific. So remember, if you're going to say something other than what the normal is, then you need to be more specific with what the actual abnormality is so that we can understand. When assessing the patient's level of consciousness, you want to be sure to assess them and use a normal voice first. If the patient has a decreased level of consciousness and they are not aroused easily, they're not aware of the situation going on, because that's basically what LOC does. It's measuring that arousal or that wakefulness and their awareness of their environment. So if they're not wakening, responding to you, we do sometimes use the word shouting, because we had to raise our voice to make sure it's not that they just aren't hearing us. And then sometimes we can try pain in order to get arousal from the patient, whereas what we call using the sternal rub, where you basically kind of take your fist and kind of just rub it over their sternum pretty forcefully. And usually if the patient is alert, but they're just maybe pretending to not be, that will wake them up. You will be able to see some response to that. So I'm going to skip to the next slide just for a second, and then we'll be going back. So there are 6 levels. We're going to say 6 levels of level of consciousness. Now this is going to vary according to textbook. I think your textbook only lists 5, on page 1871. But again, it varies. So we're going to go with 6 here and discuss 6 different levels. And of course, again, this is going to go This is based on arousal and awareness. So obviously, if they're alert, that's the highest level of consciousness. Comatose is the lowest level of consciousness. So each of these, regardless of what your book uses, it's usually going from, awake to not responding at all. So kind of just varies again. So if you say that your person is alert, that means that they are going to respond appropriately to speech, touch, or light. Okay, so you walk in the patient's room, you say their name, they look at you, they open their eyes. That's alert. Or if you turn the light on, or if you touch them, they look at you, they respond. That is considered to be alert. Disoriented or confused. So you'll see both of those used sometimes. But this means that they're basically unable to follow simple commands. Sometimes their thinking is slowed. They may be inattentive. And oftentimes your person may be oriented to person or to self, but then they're not to time or place. So if you see disoriented, most of the time, a lot of times the person does still know who they are, but they're unable to tell you the correct time or place. Lethargy, this is just described as having limited spontaneous movement and speech, but the patient can be aroused with normal speech or touch, but they may or may not be oriented. So if you walk into your patient's room and they appear to be sleeping, their eyes are closed, um, and you walk in the room and they kind of just barely open their eyes, but they don't pay any attention to you. So it's kind of that limited spontaneous movement and speech. But if you start talking to them and you actually touch them, start making noises, then they actually kind of wake up. But sometimes they may fall back asleep. There's the next one is stupor. But before I go to stupor, you might just make a little note here underneath lethargy and put obtunded in your notes. Obtunded is OBTUNDED. So obtunded is actually a level that your ATI book uses. So I just like to bring those out sometimes and also mention those. So obtunded basically just requires repeated stimulation. The patient, maybe they respond, they're lethargic, but they're obtunded because you have to continue to stimulate them in order to follow commands or directions. They may respond to light shaking, but they could be confused. They may be slow to respond. The next one is stupor. Stupor is characterized by deep sleep. Oftentimes, they're very difficult to arouse. They seem like they're unaware of their surroundings, and typically they're only aroused by vigorous and continuous external stimuli. They may respond to verbal commands, but they're going to respond with like groaning, moaning, or like grabbing something. If they're probably not going to actually be able to quote unquote communicate with you. Semi-comatose. So again, this is mentioned in your book, and I probably have very rarely seen semi-comatose used, but it is in your book. So I wanted to make note of it. But basically, semi-comatose is going to be an impaired state of consciousness, which is characterized by stupor, and then they're only aroused by energetic stimulation. So it's just one step less than stupor. It's one step more, I guess, of a decreased level of consciousness. Your stuporous may respond to your verbal commands or by maybe just kind of going up to the bed and touching them and kind of shaking them a little bit. But with the semi-comatose, they're going to have that more vigorous, you have to put in more energy and probably continuous, keep shaking them or keep giving them the sternal rub in order for them to stay awake. And then, of course, comatose is just going to be when there's no motor verbal response and there is no arousal to any stimuli. So this patient, of course, they typically, they don't swallow, they don't cough, they're probably incontinent to urine and feces. So they are not aware and there's no response at all to be considered comatose. Okay, so going back to this slide here, then the next section of the mental status is the orientation. So we're going check to see if our patient is oriented to person, place, and time. And we're going to be asking them things such as, tell me your name, what is the name of this place? Tell me where you live, what day is it, or, depending on the age of your patient, the situation, they may not know the specific day, but they might know the month or the year or even the season. So those are some things that you ask them to obtain orientation status. You do want to be sure to rephrase and vary your questions because the patient may learn to answer questions by memorization and repetition. So just maybe kind of try to change it up a little bit. Remember, when you're documenting orientation, you have to document that in specific terms. So you want to document oriented to name, date, and hospital, or you might say oriented times 3 instead of just simply charting oriented. So if you're going to say they're oriented, you need to be specific with what they are oriented to. And the only time you can use a times 3, a times number, is if they are oriented to all 3, person, place, and time. So if they are disoriented to one or the other or more than one, then you have to be specific and explain oriented to person, disoriented to place and time. And it's really good to just use actual statements made by the patient in order to be able to explain more specifically why they're not oriented or how you know they are not oriented. So you can't just say disoriented. Also, again, be specific and explain how you know that, and use the patient's actual statements. You may also look at their general appearance. You can also look at their short and long-term memory. So you may question about recent and past life events. And then also you may look at their attention span, their ability to concentrate, and just some general knowledge. If you'll remember some of that from the mental status exam, do they know who the president is? I think we used to say, where does the sun set? So just general information. Okay, so the next assessment is the patient's affect. So remember, the affect is going to be that outward facial expression. So you're looking at their their facial expressions that they make, the outward display of their emotions. And we want to make sure and check to see if it matches their speech or if it matches their mood. So remember, there's inappropriate affects, or there's appropriate affect, or the affect matches the mood. So remember, this is part of that psychosocial part of your data collection sheet when you are doing your paperwork for clinical. This is where you should be putting this information. Also, the next one is mood. So the mood is going to be that subjective way or feeling of how the person actually feels. Remember, they may be, they could be depressed, they could be euphoric. Sometimes we may have to ask them questions about being suicidal. Do they have increased irritability or agitation? Is their mood labile? Remember, that's where they go from one to the other, or maybe the mood doesn't match the affect. Should make eye contact with you, and then their emotions should correspond to the situation as well in order to, when you're assessing their mood. You can also assess this by inspecting their mannerisms and the actions during your interactions with them. So you ask them how they feel today, and they say they feel good, in a good mood, and does their affect match that? Are they smiling? Do they seem like they feel good? You can just kind of tell from those outward displays of their emotions. Okay, so the next area of the mental status is the patient's speech. You're going to assess their speech. So we are going to, and just as a review, remember, speech is a function of that dominant hemisphere. So usually on the left side of the brain for right-handed people, and it's on the right side of the brain for left-handed people. It is important to note that any injury or insult to the brain may cause damage to the speech ability, so such as mumbled speech or slurred speech, or of course can even cause the patient to have an inability to speak. So just some terms that you want to be familiar with. Aphasia is the absence or impairment of the ability to communicate through speech, writing, or signs. And this does include all areas of communication. So it includes speech, includes reading, writing, and also understanding. So aphasia is the absence or the impairment of the ability to communicate. So there are some different types of aphasia that we'll talk about. There's 3 main types. There's sensory, um, or receptive, there's motor or expressive, and then there's also global aphasia. So those are the three main types. And then anomia and dysarthria are just some other terms that are related to impaired speech patterns, and we'll talk about those. So sensory or receptive aphasia is going to be defined by the inability to understand the spoken or the written word. So the patient can hear or see, but they do not understand. Sometimes um, you'll hear this referred to as Wernicke's aphasia, meaning that meaning that it affects their language and their comprehension. So sensory or receptive, so they have an inability to understand what you are saying to them. They can hear you, but they do not understand what you're saying. So we need to make sure that for patients who have sensory receptive aphasia, that we're giving them very short and simple sentences. We cannot give them long instructions or directions on to do something, or it has to be very simple, very short, because again, it's sensory, it's receptive. They do not understand what they're being told. Oftentimes, these patients also kind of speak in nonsense. So they can still speak, but they don't really understand what to speak. So the things that they say do not make sense. There's also motor or expressive aphasia, and this is defined by the patient understands the spoken word, but they're not able to respond due to the inability to coordinate the muscles that control the speech. So they know what they want to say, but they're unable to say what they want to say. So again, they understand it, which is opposite from sensory or receptive, but they are just unable to respond because they're not able to coordinate the muscles. So we need to give these patients extra time to respond, and also we need to give them yes or no questions, because yes or no answers will be a lot easier for them to respond with. They also may have like a writing pad that they use in order to be able to communicate. They also may speak in short phrases. So, like, instead of saying, I will take the dog for a walk, they might just say, walk dog. Okay. So, again, they understand what you are saying to them, but they cannot respond back to you because they have that inability to coordinate the muscles. So, sometimes this is referred to as Broca's aphasia because Broca's area affects the motor speech. So, if their infarct, occurred in the Broca's area, then they are going to have problems with motor speech. If their infarct occurred in Wernicke's area of the brain, they're going to have a hard time with language comprehension. Okay, so it's very important to make sure that you do understand the differences between sensory and motor aphasia, or if receptive or expressive. So it's sensory and motor because that's the areas of the brain that's affected, but sensory is a receptive problem, and then motor is an expressive problem. So kind of try to make the connection there with those. And then global aphasia is just going to be the failure of all forms of communication. So this means basically that the patient is unable to understand the spoken word, and they are unable to speak. So it's kind of both of the sensory and motor together. And then just a couple other terms here. You have anomia, which is the inability to name everyday objects. So anomia just means that the patient cannot, just simple clock or pen. They have a hard time being able to name everyday objects. And dysarthria is considered a motor speech disorder. And this is where they have difficult or poorly articulated speech that usually results from interference in the control over the muscles of speech. So this tends to be a muscle problem. So it would be possible for a person to have expressive aphasia or motor aphasia and then also have dysarthria. Again, it's just a term to explain a type of speech disorder. So a lot of times these patients, they sound like nasally. They have that nasal sound, or they may have like a breathy speech. Or maybe like where they have a strained or a hoarse voice. It's just hard you can just tell that of course, the dys is difficult, and the arthria means speech. So that difficulty speaking. They may have frequent hesitations where they kind of hesitate to speak a lot. Parkinson's disease patients tend to have dysarthria a lot because they kind of have just this monotone speech. Um, they may also talk excessively loud, or they could have very quiet speech as well. So, um, and again, this can be caused by stroke, Parkinson's disease. They can have a brainstem injury, or even cerebral palsy can cause dysarthria. Okay, and then the last section of the mental status assessment part is going to be the cognition. So, cognition is going to be judgment and abstract ability. So, again, this should be a review from mental health. So, remember that judgment is when we ask the patient questions about solutions to certain dilemmas or problems. So, like, for example, what would you do if you locked your keys in your car? And so we know a lot of times with mental health patients, they do not have good judgment. They're not able to, have that um, ability to be able to make good judgment in situations. But also patients who have neurological problems, just, if they've had stroke or depending on, again, just whatever area of the brain is affected, they can have problems with judgment. They don't have good judgment. And then abstract ability, again, is being able to interpret those cliches, or, do they have that ability to abstractly think? And so the example that we always give or we use for them is giving them a cliche statement or a proverb. Do they understand the meaning of a proverb? What does it mean when I say it's raining cats and dogs? And again, sometimes in persons who have neurological problems, they may not be able to think abstractly. Okay, so this is going to conclude the first part of the neurological assessment, and this was the mental status.